Hello and welcome to the AJNR Podcast. I'm your host, Francis Deng, a neuroradiologist at Johns Hopkins and the new podcast editor for the American Journal of Neuroradiology. Today, we're discussing a very timely topic, the evolving role of brain PET imaging in Alzheimer's disease, especially now with the arrival of new treatments. I'm thrilled to be joined by Dr. Anna Franceschi, a neuroradiologist and director of dementia imaging and director of molecular neuroimaging at Lenox Hill Hospital in New York and associate professor at the Zucker School of Medicine at Hofstra Northwell. She is also senior editor for molecular neuroimaging at the AJNR. She's the first author of the recent State of the Practice paper titled Clinical Role of Brain PET in Alzheimer's Disease in the Era of Disease-Modifying Therapies. Anna, thanks and welcome to the podcast.
Thanks so much for that warm welcome, Francis. I'm really happy and excited to be here to share this important information.
Your paper comes at a moment where there's a change in the scene for Alzheimer's disease with the recent FDA approval of anti-amyloid monoclonal antibody therapies. And so the landscape of Alzheimer's disease management is shifting dramatically, which has implications for the diagnostic imaging as well. What was the main motivation for you and your colleagues at the ASFNR, the American Society of Functional Neuroradiology, to put together this update for neuroradiologists?
Yeah, so once these new disease-modifying therapies that, as you mentioned, target beta amyloid entered clinical practice, very shortly thereafter, the CMS kind of confirmed that they would cover the medications broadly. And in addition, they finally lifted these long-standing restrictive non-coverage determinations that were made for amyloid PET nearly a decade ago. And this essentially led to an exponential increase of brain PET and specifically amyloid PET in clinical practice. For example, at my institution at Northwell Health, we went from scanning maybe 5 to 10 patients over a course of a year that were predominantly self-pay patients to scanning anywhere between 50 and 80 cases a month. And those numbers have been holding strong. And in talking to a lot of my colleagues at the ASFNR, of which many of us have a vested interest in dementia and neurodegenerative disease, this has been the trajectory across the country. And of course, brain PET kind of serves as an intersection of both the nuclear medicine and neuroradiology. And we are slowly but surely seeing increased presence of PET and PET MRI training in neuroradiology fellowships program, and also neuroradiologists interpreting these cases both in academia, but also in private practice.
Excellent. So let's talk a little bit about the image interpretation. And for those of the listeners who have access to the video version of the podcast, they can look at the video to see some of the figures in this paper. So the interpretation of neuroimaging kind of fits into this ATN framework, amyloid, tau, and neurodegeneration, that's central to our current understanding of Alzheimer's disease. Can you walk us through the roles of amyloid PET and tau PET in the current clinical context? And while you're talking, I'm going to pull up the figures to show some of the imaging findings, and hopefully you can explain some of that as well.
Yeah, so you mentioned the ATN classification, which was developed by the Alzheimer's Association and the NIAA as initially as a research framework, but it's definitively translated into clinical practice where we've seen a shift from a phenotypical or clinical diagnosis of Alzheimer's disease and related neurocognitive disorders towards a biological biomarker-based definition. And we're super lucky in the United States to have FDA-approved imaging methods for all segments of this classification. The A stands for amyloid. Obviously, we have amyloid PET and 3 FDA-approved F18 labeled agents. The T stands for tau. And in this case, we have a single agent F18 for tau superior that's approved for clinical use. And then the N, which stands for neurodegeneration, we can image either using volumetric MRI or FDG metabolic PET. I'd also like to just highlight for the listeners that there's been a recent update to this ATN classification or to the biomarker-based classification of neurodegenerative diseases that was published late last year. And essentially, all of these biomarkers, be it imaging, CSF, or plasma, are now divided into the so-called core 1 biomarkers or early stage biomarkers that define the initial stage of disease that is detectable in vivo, and amyloid PET falls under the core 1 biomarkers, and then the later stage core 2 biomarkers, which correlate far better with the onset of clinical symptoms, and tau PET stands for the imaging component of core 2 biomarkers. And with the addition of core 2 biomarkers such as tau PET, we are able to stage biological disease severity and also then predict the rate of cognitive decline in patients who are symptomatic, the estimated onset of clinical symptoms in asymptomatic patients. So we're really able to give information on both disease severity, staging, and offer prognostication. So this image here shows a classic positive amyloid scan. We see the grayscale image of the amyloid PET, where we see radiotracer uptake not only in the white matter, but extending throughout the neocortex. So that's a classic positive grayscale amyloid PET image. In the center, we have a T1-MP RAGE volumetric MRI. We notice some biparietal atrophy on this transaxial slice that we are imaging. And on the right-hand side is the PET MRI fusion image. And you can imagine that, especially in patients who have advanced atrophy, having the hybrid option of both the PET with the superimposed volumetric MRI really allows you to make the most appropriate assessment.
So the positive amyloid scan has diffuse cortical uptake, and let's contrast that with the negative amyloid scan.
Exactly. And in this case, on the left-hand side, we have a grayscale negative amyloid PET image. You can appreciate that there is uptake of the agent only in the white matter, but it does not extend to the gray matter of the neocortex. In the middle, again, we have a T1-MP RAGE volumetric MRI image for anatomic correlation. And then on the right-hand side, the fused image. And you can, again, appreciate the difference of uptake only in the white matter, not extending to the cortex. I would just like to add that since this article has been published, and actually since late June of this year, the FDA approved an expansion of the labels for all 3 amyloid PET agents, and they added quantification as a part of the assessment for these scans. So quantification, usually using the Centiloid scale, can now be used as an adjunct to visual reads. And in my experience, this is particularly helpful in those indeterminate scans. You can imagine the 2 examples that we highlight in the article are, clearly positive and clearly negative, but depending on your referral base, anywhere from 10 to 15% of these scans might be visually indeterminate. And in these cases, it's really helpful to have quantification tools available as well.
I've heard of the Centiloid scale, but it seems to me that it requires some special software. Is that right? And then can you explain the general interpretation of the number that is output?
Absolutely. So you're right. The Centiloid scale does require specialized post-processing softwares. There is currently 5 FDA-approved softwares for Centiloid quantification in the clinical setting. The most commonly used include MIMS, MIMNeuro, and Siemens Singo programs. Personally, I use MIM at my institution. And, when looking at the Centiloid scale, it was initially, back in 2017, developed as a quantification tool for multi-center research collaborations. And the idea is that you wanted to have a single number that can be compared across different agents, so different radiopharmaceuticals, different protocols, different scanners. So all these variations that may affect your final quantitative result are based off of the SUVRs from the GAIN data set. And basically, the scale has 2 anchor points, a Centiloid score of 0, which translates to the mean average signal in young, healthy, cognitively unimpaired controls, and a Centiloid value of 100 that is the typical amount of beta amyloid burden in the cortex of patients with moderate Alzheimer's disease dementia. It's important to remember that the scale is a continuum, so patients can have values below 0 and also above 100, so don't get surprised there. There are some key cutoff points to keep in mind, including a Centiloid score less than 10, which effectively rules out Alzheimer's disease. It indicates that beta amyloid plaques are absent. A score greater than 20 typically indicates mild to moderate plaque burden, and a score of 50 and greater indicates it has a best correlation with Alzheimer's disease dementia. I will just add to that the Centiloid score was used for the phase 3 trials of the currently approved disease-modifying therapies. And the cutoff points for these trials for both inclusion and assessment of treatment response were around 30. So typically patients were enrolled if they had a Centiloid score of 30 and above. But with that being said, depending on the clinical trial, the mean Centiloid score of the patients in the trials ranged between 75 and 95. Similarly, depending on the agent, when assessing for treatment response, in the Leqembi or lecanemab trial, Centiloid score less than 30 was considered negative. And for Kinsula or donanemab, it was typically 2 consecutive scans with a score less than 25 or a single scan with a score of 11. So there are some distinctions here, but again, clear cutoff values that are available. And there are 2 excellent review articles on this topic. One by Pemberton that was published in the European Journal of Nuclear Medicine and Molecular Imaging, and the other one more recent from last year by College. And again, both review the currently available tools for quantification of amyloid PET in the clinical setting, and I highly recommend them to readership.
Given that they were used as inclusion criteria for these therapies, we're seeing more neurologists and psychiatrists who treat Alzheimer's disease request this being reported. It's no longer sufficient just to give a qualitative interpretation of whether an amyloid scan is positive or negative, right?
That's correct. And it's particularly important as patients are getting to the 18-month mark when a treatment response was typically assessed in clinical trials. So once you could rely potentially on the visual read to enroll patients, the big problem then becomes when you want to monitor target engagement and treatment response, it's really difficult to compare without having set numbers. So you're absolutely right. At my institution, even when patients get their amyloid PETs outside of the health system, if the Centiloid score isn't available, the neurologist will typically reach out and ask me if I can post-process the external imaging for them to have a baseline, both for, at the start of therapy, at initiation, but then perhaps even more importantly, for monitoring treatment response. Because currently, patients are being started on these treatments based on their CSF or their plasma biomarkers more recently. But both of these, again, become problematic when you want to assess treatment response and you don't have the quantitative availability that amyloid PET provides.
Got it. And you mentioned that there are 3 different agents for amyloid PET. I presume that the software can take into account which agent you're using and adjust accordingly to give a more standardized measurement. Is that right?
That is correct. The cutoff values for the different agents for the SUVR metric typically differ between the tracers, but the software automatically detects which agent was used, typically off of the DICOM headers, and then they post-process accordingly. So they do differentiate between the 3 agents. And again, just for the listeners, the 3 agents are Amyvid or florbetapir, Neuraceq or florbetaben, and Vizamyl or fludametamol. They've all been approved for clinical use in the United States for the last 10 years or so, and they're quite comparable. All 3 have above 90% sensitivity and specificity for detection of increased amyloid cortical burden. Currently, at my institution, we are using 2 of these agents, and we are in the process of contracting with the 3rd one as well. And again, I think they can be used quite interchangeably. They all perform remarkably well in the clinical setting.
Wonderful. Let's pivot to a discussion of tau PET. So this is a little bit more experimental, I suppose. Can you walk us through the use of tau PET and what the images might show?
Absolutely. So, tau PET has become interesting in the clinical setting ever since the phase 3 trial data had been published for donanemab. And what Lilly did in that trial is that they, at enrollment, they did not only have the patients have an amyloid scan, but the patients also had a tau scan and were stratified according to their tau burden. And when they went ahead to assess treatment response, what they clearly shown was that there was a statistically significant difference. And those patients with lower tau burden at baseline, meaning at earlier stages of disease, performed far better on these disease-modifying therapies than those patients that had high tau burden at baseline. So slowly but surely, we are in fact seeing the emergence of tau PET in the clinical setting. At my institution, we scan about 3 to 5 tau PETs a month. They are currently CMS reimbursed. They're reimbursed by NGS, our local MAC. The classic indication in this setting where we still do not have tau targeting therapies available is precisely patients who are amyloid positive, who are contemplating the start of these disease-modifying therapies, and also those that have concern then for side effects such as ARIA, and they just want to predict their successful treatment response. And again, typically patients with lower tau burden on imaging are those at earlier stages of disease, and those patients, it's been clearly shown in clinical trials, go on to have far better results on these therapies. So this example that we have here of a positive tau scan, it was actually performed with PI 2620, one of the second generation tau tracers that does not have FDA approval as of yet. But the pattern we are seeing is a typical pattern seen in patients with Alzheimer's disease. So we can appreciate on the axial view uptake in the parietal regions, parieto-occipital regions, including in the precuneus and posterior cingulate gyri. When we take a look on the sagittal and coronal views, we will appreciate that the uptake involves the temporal lobes and, importantly, the lateral and the inferior temporal regions. And then focusing on the middle sagittal view, you will see that there is extension of tracer binding into the frontal lobes, which suggests that this patient has advanced disease or relatively high tau burden. I mentioned that there is a tau tracer that is FDA approved. It's called fluortaucipir. It goes under the trade name Tauvid. It's had FDA approval since 2020, but we've really seen it emerge in clinical practice over the last year or so since these disease-modifying therapies have taken off. Like I said earlier in our discussion, at my institution, we perform about 3 to 5 scans a month, and I'm familiar with a handful of institutions across the country also performing tau PET in the clinical setting. I think the important point to highlight for the audience is that there is reimbursement for these scans, and we have just recently finished a review of the tau scans performed in Northwell earlier this year or up until August, and we did secure successful reimbursement by NGS, our local MAC, for all of these studies. So it seems like reimbursement is also starting to come through, which is, of course, an important consideration for all of us.
To summarize, the positive tau scan has tracer uptake in the lateral temporal lobes and the precuneus. So how come there's not medial temporal lobe uptake?
So there usually is medial temporal lobe uptake, but isolated medial temporal lobe uptake is not currently acceptable as a positive scan per the current prescribing information. So even in cases where you will appreciate uptake in the mesial temporal lobes, if it is isolated to the mesial temporal lobes, that is not sufficient to call a scan positive. Similarly, isolated uptake in the frontal regions is not sufficient to call the scan positive for Alzheimer's disease. And again, the key regions that we assess are the inferior and lateral temporal lobes, the parieto-occipital regions, and then the posterior cingulate area. And it's a kind of typical pattern that we see across the different tau agents, both first-generation tracers such as fluortaucipir that are currently in clinical practice, and also the emerging second-generation tracers such as PI 2620 or MK 6240 that are being used widely in the research arena at this time.
And how about a negative tau scan?
Yeah, so this is an excellent example of a negative tau PET, at least from these views that we present here, the axial, sagittal, and coronal. You can see that there is no evidence of a significant neocortical uptake of the agent in any of the regions that we discussed. There is some off-target binding. For example, on the sagittal view, you can see that there's uptake in the cerebellar vermis and the superior vermis. That's a frequent target of uptake. There's uptake in the dural venous sinuses. also in the nasal mucosal surfaces, the parotids. So there's a few areas that we see here. I will highlight that one of the benefits of second generation agents that are currently in development is that they try to address some of the off-target binding that we see with first generation tracers. So typically fluortazepir, which is the clinically used agent, will have binding in the subcortical structure, so in the basal ganglia and the thalami, in the substantia nigra of the midbrain, and then perhaps most importantly in the choroid plexus. And the problem with the choroid plexus uptake is that the binding in the choroid plexus and the temporal horn frequently limits hippocampal uptake and can hamper our assessment of the temporal regions on these scans. So again, that is the main reason for the second generation agents that are trying to address some of the shortcomings of the tracer we have currently available for use in the clinical setting.
Perfect. So let's pivot a little bit to brain MRI, which neuroradiologists will be more routinely familiar with. In this new era of brain PET for amyloid and tau kind of diagnostics and determination of eligibility for treatment of Alzheimer's disease, what is the role of MRI still? Often in the early stages of disease, we don't see the clear hippocampal and parietal atrophy that we do in the later stages of disease. So how should we approach reporting these MRs, and how does it fit with the obtaining of PET in these patients? Should we be getting both together and interpreting both together, or what is your approach there?
That's an excellent question, and I think I'll give a twofold answer. The one pertains to safety monitoring for these drugs. This article doesn't go into so much detail, but these agents do have side effects known as ARIA, or amyloid-related imaging abnormalities. There are subclassified ARIA-E, which stands for edema, that we typically assess on the T2 flare sequence, and ARIA-H, which stands for hemorrhages, classically microhemorrhages or superficial siderosis, that we assess using the GRE sequence or susceptibility-weighted imaging. So classically, patients that are being considered for treatment, in addition to a positive amyloid scan, will be required to have an MRI brain at baseline within 3 to 6 months of treatment initiation, and then serial MRI scans for safety monitoring for the emergence of ARIA. And just to give your listeners an idea, typically every patient will have between 4 to 5 MRI scans in the first year of treatment. So again, one group of MRI scans that is relevant for these patients is for therapy safety monitoring. However, the second part that is quite important is the structural information and anatomic correlation that MRI provides, even in patients that undergo PET-CT imaging. So as we're all well aware, while there are a couple of centers that are performing PET MRI in the clinical setting with quite impressive patient volumes, PET-CT is still the most frequently used modality across the country. That being said, there are various post-processing tools such as the MIM platform that enable fusion of a PET from the PET-CT with a separately acquired MRI brain. And as long as this MRI brain is relatively recently acquired, for all intensive purposes, especially in patients with neurodegeneration, the fused PET MRI images from a PET-CT and separately acquired MRI brain perform almost just as well. And in my experience interpreting these studies, when I am quote unquote stuck with a PET-CT only patient, I always feel that I am interpreting the scan blind. I think the MRI component really adds anatomic correlation, adds significant value to interpretation of brain PET, be it an amyloid or tau scan, and perhaps especially an FDG metabolic PET that is still quite present in clinical practice.
Your paper notes that about 5 to 8% of patients with Alzheimer's disease would be qualifying for these new monoclonal antibody treatments, and that really translates to an exponential rise in PET scan volume. What are the challenges for radiology practices that aren't doing a lot of these to scale up to meet this demand in their community?
Yeah, I will tell you that at my institution, our brain PET volumes are up more than tenfold over the last 4 years. And in fact, when we looked at our numbers for 2024, we were up 85% compared to 2023 for the brain PET volume, which is really incredible. We've been very lucky to, at the same time, have opened a couple of, specifically 3 outpatient PET facilities. So we were able to accommodate patient volume from the scanner side of things. However, we have had a lot of trouble finding qualified techs to scan these studies. And then, of course, the other side is to find radiologists and nuclear medicine physicians who feel comfortable interpreting these cases. Historically, brain PET has not traditionally been part of neuroradiology fellowships. So while many neuroradiologists are comfortable with reading MRI brain studies for both dementia assessment or even ARIA follow-up, they are not comfortable yet in interpreting brain PET cases. And similarly, a lot of nuclear medicine residency and fellowship programs primarily focus on oncology, more recently diagnostics, but their neuro-nukes training has been lacking. So I think across the field, when you look at key opinion leaders, there has been a significant push to really expand access to appropriate training for brain PET, because quite frankly, we don't have enough radiologists there to meet the increasing demand and the exponential rise in volume.
This is a great segue to my next question, which is about another paper that you have published recently in the AJNR, and this is an ASNR consensus statement on integrating neuro-PET interpretation into neuroradiology training and practice. So what do you see as the potential role of neuroradiologists in neuro-PET in the future, and how do we enable that in fellowship programs and for those radiologists currently in practice?
Yeah, so, especially more recently with the advent of both simultaneous PET MRI scanners, but the increasingly common practice of fusing PET-CT images with pre-existing MRI studies, neuroradiologists are, I think, slowly but surely becoming indispensable in the molecular neuroimaging field. Neuroradiologists have an in-depth expertise of central nervous system structure and function. They are familiar with traditional anatomic findings that perhaps nuclear medicine physicians are lacking. So with this increase in neuropet imaging volumes, I think there is a great need to really focus on neuroradiology training pathways, implementation strategies for brain PET in neuroradiology practice, and competency recommendation. So recently, this group of experts in the field really came together and put together guidelines and suggestions on both training radiologists, meaning residency and fellowship programs, and then also options for practicing neuroradiologists to familiarize themselves with brain PET interpretation, since this really is becoming a requirement. And again, not only in academia any longer, but now in private practice as well.
Wonderful. Yeah, I want to ask you one last question, bringing this discussion back to Alzheimer's disease, which is, where do you see PET imaging fitting in with the rising use of CSF biomarkers and blood tests, as you alluded to earlier? Is there a competition with imaging, or is it more of a integrative, collaborative process?
Yes, that's a fantastic question. And I think from that standpoint, one of the big developments in the field was right a week before ASNR this year. So in May of 2025, the FDA approved the first plasma biomarker for clinical use, which was a key milestone. Up until this May, the two methods that were acceptable for starting patients on therapies as an inclusion criteria were either amyloid PET or CSF biomarkers, but the blood-based biomarkers were not cleared yet for clinical use. Now that is changing. When I think about future direction of the field, I actually think that we will see a shift away from CSF and towards plasma testing. So I think we'll actually see a decrease in the number of orders for LP and CSF now that easily acquirable blood-based biomarkers are available and acceptable to start patients on therapy. However, I don't think that molecular neuroimaging is going anywhere. Amyloid PET is unique in evaluating therapy response, and we will likely continue to see a rise in the 18-month follow-up scans for patients on therapies. FDG PET or metabolic PET is indispensable in the workup of more complex patients, especially those with mixed dementia and co-pathologies. I'll just put out a statistic that looking at community-based autopsy cohorts in elderly patients with cognitive impairment, 80% of subjects will have at least 2 co-pathologies. 60% of subjects will have at least 3 co-pathologies. So as you can imagine, especially in high elderly individuals, Alzheimer's disease exists as a co-pathology in a picture of mixed dementia. And then, tau PET is just emerging. And for now, there's relatively variable use across the country. But looking at the AD drug development pipeline, there are a couple of anti-tau targeting therapies on the horizon. And I think once those emerge into clinical practice, we will see a rise in tau PET across the country as well.
Wow, that's very interesting. This has been an incredibly insightful discussion. It's clear that neuroradiologists are going to play a bigger role in the future in Alzheimer's care and potentially even in the interpretation of neuropets. But there are many challenges to get us there. And Dr. Anna Franceschi, thank you so much for sharing the highlights of your work and the collaborative work with the ASFNR and the ASNR committees that you're on. And thank you for joining us on the podcast today.
Thank you so much, Francis. This was a great experience for me, and I hope to be back soon to give you further updates on this really rapidly evolving and exciting field. Thank you for having me.
For our listeners, you can read the full paper by Dr. Franceschi and her colleagues on the AJNR website. Thanks for tuning in.